everybody here. I wanted to just give a little background about medical errors. This is something that Florida does. This is not something that's done universally. Different states have different requirements for continuing education. The requirements that Florida requires are very different than Colorado or California or different ones. I'm going to say about 15 years ago, and Annalyn can probably remind me, I was in one of the first medical errors, and it was for all members of the regulatory agency careers. And I was in with doctors and nurses and pharmacists and all of these folks. And what I realized was two things. One, it had no relevance to me as a marriage and family therapist. And two, I would never go to a hospital if I could possibly avoid it. Because I heard so many medical errors that doctors and nurses and pharmacists did that, that really freaked me out. And realized how we do have, we can have medical errors. We can do medical errors, but at a lot less liability, I think. One of my very best friends in Florida's husband was a neurosurgeon, and his malpractice insurance back in the 90s was $500,000. Our malpractice insurance, as you probably know, is a lot less than that. I pay, like with CPH, I would say less than a couple $100 every year for mine. So that just lets you know that if our insurance is that low, generally our liability and our medical errors are a lot lower than, say, a neurosurgeon. Some of the kinds of, we can begin to put the PowerPoint up. But one of the things I was thinking as I'm doing supervision and I'm doing therapy, here's a couple of the issues that I'm hearing from my supervisees and from myself. As a teletherapist, how do I know if I'm practicing in my state? Okay, so we are licensed in our states, the licenses we hold are from our states. Now with teletherapy, can I be assured that my clients are in the state that they say they are in? Am I performing therapy in the state that I'm licensed in? And always where our clients are located is where we're doing therapy. We may be in Broward County doing therapy, but if your client is in Boulder, Colorado, you're doing therapy in Boulder, Colorado. That's one question that's come up for me. How do I do a risk assessment? And I think Heather said this. How do I do a risk assessment over telehealth? And how do I document that I've done that suicide assessment or risk assessment? And what do I do if a client is suicidal? We might know what we do if that's in our office. We might know how to do a Baker Act, or in Colorado, it's called an M1 hold. But how do we do that? And how do we document that we've done that effectively over telehealth? One of my supervisees asked me another question. She said, I have a very small practice in a small town. And she's doing face-to-face. And she said, if one of my clients tests positive, do I have to inform the other clients who were there that day? And does that expose my client? Does that expose her confidentiality or HIPAA? So what do I do if a client tests positive? And I have another intern that just said the other day, my client thinks her husband is lurking outside the door. I can't assure my client of confidentiality as I could if they were in my office where I have a sound machine and I have a locked door and things like that. So how do I assure confidentiality? I'm sure you all who are doing telehealth are coming up with the same amounts of questions that my interns, myself, and my colleagues are coming up with around telehealth. And I'm not sure. I'd like to use this time more as kind of, I'm no expert. I'm no more expert than any of you. You guys, many of you, some of you have been in the field longer than I've been and probably have much more thriving practices than I do. So I like to use this time more as like, how can we do best practice here? So you can advance the slide, Annalyn. These are the objectives I'm believing that Florida is putting forth, okay? You probably have seen those every 4 years you have to take this course now, right? Is it every 2 years? Okay, I thought it was every 2 years you take a set, and then every other 2 years you take a set, but no, it's every 2 years you do all of them. Okay, so let's, so some of the challenges of professionals and clinicians in creating and managing documentation, I want to talk a little bit later, or if this is relevant to you guys. Domestic violence, telehealth, I don't have that on there, suicide and child abuse. So that's something we'll probably be batting around. And I don't know if I can't see everybody, but if there's ever somebody who wants to break in and talk about something, please do. I'd like to make this more of a conversation. Some of the medical errors in the hospital are what happens if you give the wrong medication to a patient. What if you don't set up their oxygen masks correctly? What if you chop off the wrong leg? I literally have heard that. So those are not our medical errors, but we have medical errors too. So some of our medical errors in the behavioral health setting are patient suicide, and that's pretty much very, very large. Now, when I worked as the clinical supervisor at Nova Southeastern University's counseling center, that was #1 on our list. You know, how do we make sure that we're documenting and that we're assessing and treating and documenting correctly folks who have SI or suicidal ideation? I think that's one of our biggies. A misdiagnosis. What happens if our treatment doesn't take or may even harm our client? We also talk a lot about loss of confidentiality or privacy, and that's happening a lot in the telehealth, like I just talked about a little bit earlier. And lost files, lost information, but also our file due diligence. And I think about, you know, who's our guardian of records? What happens if we pass away unexpectedly from COVID? You know, who's got our records? And what due diligence do they have, or we have, in terms of that? We can, so these are just some. Okay, well, does anybody have any others that are keeping them up at night? In the behavioral health setting? I don't hear anybody, so I don't. Okay, those pretty much cover it. Okay, so a lot of times when we're thinking of medical errors, we're not thinking of the couple that's coming in for a checkup once a month and doing really great. You know, they're very low risk. We might have other folks that are really low risk on our caseloads. But what we're really thinking about when we're thinking about the potential for a medical error is our high-risk clients. Our high-risk clients always include, of course, our suicidal clients, highly depressed clients. And if we accurately and adequately do a good suicide assessment. Now, I've been trained, and probably many of you know Douglas Flemons. So Douglas Flemons and Len Gralnick wrote a book called The Relational Guide to Suicide Assessment. And we wrote it from clients and students, about most of my clients, because I was the crisis counselor there. So we were really having to document well our suicide assessments, our safety plans. And why would you do a safety plan and not a contract? Contracts can be more dangerous than safety plans. So it was really important to know about this suicidal doing a correct suicide assessment, and then how you document that. Another high-risk client is one that harms self or harms other, who might disclose to you homicidal behavior. Domestic violence assessment, even though we're going to talk about confidentiality in a little bit, domestic violence, if someone reports domestic violence to us, we have no ability really to breach confidentiality and call the police or anything like that. That has to come from the client. And knowing that a client who is experiencing domestic violence or intimate partner violence, when and if they decide to leave their partner, are at very great risk of of death. So that can be a really high risk client. Substance abuse clients and others. What are other clients that again, think of your caseloads, and what are some clients that keep you up at night? Nobody?
I think the only one that I would add to that list, and from my experience in other jobs, is child abuse or neglect.
Okay, right. Child abuse or neglect. So we're going to talk a little bit about, when and if and how to report child abuse and neglect. I had, and somebody who was actually a professor and taught ethics also at Nova Southeastern when I was teaching ethics there, called me once and said, I have a couple, and she worked in Weston. I have a couple who just came in and was having a fight, a physical fight in front of their children. What do I do? Is this, what, and the gentleman was an attorney. And I said, well, according to Florida statute, that is a that falls under child neglect, and that's a report. So she called her clients and told them that she was going to have to report that, at which point her client said, I'm going to sue you for breach of confidentiality. So that might keep you up at night too. So if you're, having to make that, report, the child abuse report, and then, really being threatened by your client. So that would have kept me up at night too. So the next slide.
Roxanne,
I
think people that work with a lot of teenage clients, so that's frequently a lot of risk, a lot of drama with their, just all that they go through.
Right. So a lot of times for me, self-harm for teenagers, like cutting behavior, that could be, are we, to what extent do we breach their confidentiality, especially if they're over the age of consent? Also, is this a suicidal gesture? Is this is self-harming behavior that's not suicidal? So that can be really keep us up at night. And how do we document? How do we assess that and document that? This of course is, this slide I just want to give credit to Larry for doing the research on this. And the research is a little bit dated, and I haven't really had time to say what is the 2020, but I'm guessing it's probably about the same. So medical claims, okay, these are so these are documented situations. I thought this was-
let me say, this came from a 10-year study that this particular liability company, I know most of us use CPH, this is HPSO, who also insures a lot of folks. And they did a 10-year study of their own. And this is all behavioral health, even though it says medical, but it's all behavioral health stuff.
Mm-hmm. So we can kind of read this together, but what I found is interesting. I can't really move my pod. Oh yeah, I can. Okay. Let me move this out of the way. Which I found, I've done a lot of lecturing in Colorado for their board, and I've done some ethics and laws lecture, and this is very similar to what the recent stuff in Colorado is. So this might be sort of universal around our states. Approximately half of counselor professional liability claims, over 50%, occurred in an office-based setting. Just want to talk about that for just a minute. Office-based settings, oftentimes folks are isolated. Practitioners are isolated. They work alone. Whereas if you're in an agency or in like our student counseling center, every week we had a staffing or a briefing, and we got help from each other. There's an article that I have in my ethics course that's called The Slippery Slope. And what it says is practitioners who end up losing their license or doing something that causes them to lose their license, often it starts with feeling isolated. They didn't have anyone to talk to. So that's really something to think about in our own, at the very end of today. I hope we're going to do what I call a therapist safety plan so that we can stay safe.
And how much more so are we isolated if we're doing telemental health?
Exactly.
In COVID.
Oh, in COVID. Right. Now, just as a nice to know, I used to have a monthly Friday. We used to meet at a local coffee shop, and there was about 6 or 7 of us, because I have a small private practice, but I said, some of us meet at a coffee shop. Well, and we would bat around cases, and we would ask people, what do you think about this case and that? But now we have a Zoom coffee meeting. We do it once a month. It's the 3rd Friday at 1 o'clock. And we get together, and we have a range, people who have they're not even licensed, all the way to folks like me who've been licensed for, a couple of decades or so. And it's great. And it's really best practice when you're, collaborating with other practitioners. Most professional liability claims involved face-to-face counseling of an individual client, Okay, this is going to make more sense when we kind of go to the next bullet. The most frequent malpractice allegation was inappropriate sexual romantic relationship with a client. It's still there. And when I was teaching ethics years ago at Nova, and I used to do it for Florida, and I do it for Colorado. I look up, I'm nosy as hell, and I want to know why people lost their licenses. And that's public record. And a lot of times it's because of its inappropriate sexual romantic relationship with a client. I always ask, and maybe you guys do too, when somebody comes in for their first session, I ask them, have you ever had therapy before? And what was that like? And I hear so many quote unquote medical errors, everything from my therapist fell asleep to my therapist wouldn't stop talking about her or himself. And my therapist made sexual advances towards me. And clients don't know that is not only inappropriate, but illegal behavior. In Colorado, different from Florida, we literally have to verbally go over our therapy agreement, our disclosure. In that therapy agreement, it says, I, as the therapist, cannot have a sexual relationship with you, the client. I literally have to say that in my first session to my clients. It could be a 12-year-old boy, or it could be a 70-year-old woman. I literally have to say that to my clients. And I don't know how many therapists in my state do that. Will verbally go over that, but I think the reason why that's important, at least in Colorado, is because of this 3rd bullet.
In Colorado, is it at that 40% still, or is it less?
I think it hovers around that, but we had some cases, and there's a couple cases that are outstanding in our history in Colorado. One is therapists were doing rebirthing. You might have remembered the rebirthing. That happened here in Colorado, where they killed a client by suffocation doing rebirthing. That was Colorado. There's also, there's a lot of cases in Colorado about sexual inappropriateness. Colorado also has a designation called a registered psychotherapist, which is not licensed, and they never had to take any therapy courses. They're registered to do psychotherapy. So it's really, and Colorado is now doing away with that designation. And we had to fight, our licensed therapists had to fight hard to do away with that. So there's a lot of shady stuff that goes on in Colorado. Or has gone on in Colorado. And we're also one of the highest states to have our licenses removed. People in Colorado are very afraid. So in Florida, I actually think Florida does a much better job with their 491 board than we do here with our board. Okay. Clients most often sought counseling for marital discord, family discord, depression, and alcohol abuse. Okay.
That was the ones who filed for claims, the percentage. Yeah.
So, and we can even think of, I think marital discord and family discord, when I think about that, I think about how slippery it is to keep confidentiality. And we're always, talking in ethics classes and ethics about what's your secrets policy or your no secrets policy. And even if you as a therapist have a no secrets policy, meaning if your client tells you, well, yes, I really am still doing that affair, please don't tell my wife. you can't say, well, remember that no secrets policy? I'm going to have to tell your wife. That's still, you give confidentiality to an individual, not a couple. You give them to an individual. So you cannot, if they verbally rescind the no secrets policy, you cannot disclose that. So, a lot of therapists don't know that they think that they're in their right because that first day someone signed and said, I agree to the no secrets policy, and they signed it. And you say, well, I have proof right here. You signed this no secrets policy. If they say, don't tell my spouse, they have rescinded it verbally. So your client can sue you or more, mostly file a claim against your license. You want to? Any thoughts about that from anybody, or questions or confusions?
It just reminds me that even though this particular workshop is not about laws and rules, it's certainly completely and directly tied to laws and rules. And even though we're supposed to do medical errors every 2 years, we only have to do laws and rules every 6 years. And that's very recent. That in Florida, that's a very recent thing. And so I think probably we get into trouble more often by not knowing our laws and rules, right, and how they change. And of course, then confidentiality, of course, is both a legal and ethical issue.
Right. So again, documentation-wise, you have to have a therapy agreement or a disclosure. Your clients sign it, and in that disclosure, it goes over the laws and rules, right? It goes over mandated reporting. It goes over all those things. So I'm not sure how you separate those things. So let's kind of go a little bit more into confidentiality and privacy issues, and hopefully this is in your documentation and that your clients have signed off understanding these terms, that they have informed consent. And there's many things that can go into an informed consent, but some of the things that's interesting that I don't often see in a lot of informed consents, and maybe yours has it, is that sometimes therapy can be harmful, you have to really talk about what might not work, how things might get worse before they get better, or if they even get better. So they come for marital therapy thinking their marriage is going to get better, then they end up divorcing. Was that in your informed consent? That's a possibility. Exceptions to confidentiality must most definitely be in your informed consent. And in Florida, the exceptions to confidentiality, and again, please correct me if I'm wrong, are really kind of 5 things. One is a court order, not a subpoena by an attorney. A subpoena by an attorney you can quash, but a court order, when the judge says, Dr. Smith, you need to disclose, you need to disclose. Another exception to confidentiality is when the client signs off, right? Or the clients sign off and say, please disclose this to my pediatrician, or to, that's fine. Third one is harm to self and others. Fourth one is child abuse, neglect, or elder abuse, neglect. Is there anything I'm missing since I've been licensed in Florida?
Court order, signed release, abuse or neglect.
Mm-hmm. Suicidal ideation, elder abuse. Yeah. Right. Okay. Well, duty to warn or notify is part of this. Of course, everybody knows Tarasoff versus the University of California, Berkeley, which went back in the 70s. When duty to warn first happened, when Prajit talked about wanting to kill Tatiana Tarasoff. Now, ironically, the therapist without a duty to warn did everything right, and even included documenting. The therapist warned the victim, the therapist called law enforcement, and the therapist documented it. The therapist was still sued, but there came off Tarasoff, the Tarasoff case. So most Florida and Colorado both have a duty to warn. There are still some states that do an option to warn, meaning they don't have to necessarily warn a victim that that their client is homicidal, or they don't have to even warn law enforcement. Now in Colorado,
yeah, for a long time in Florida, we did not have a duty.
Mm-hmm.
For a long, long time.
Mm-hmm.
And so our duty to warn is relatively recent.
Mm-hmm. And in many states, I think. Now, of course, I'm going to go back to Colorado. You know, we've had Columbine years ago, I'm going to say 15 to 20 years ago, Columbine happened. And then more recently, the Aurora movie shooting happened. In Colorado, now most duty to warn is you warn the intended victim, so of imminent a harm. Okay, in Colorado, the warning is if you know if your client says there's not an intended victim at all, but they just want to shoot up a movie theater, or they just want to shoot somebody, no intended victim. We have a duty to warn at that stage. So if a person is generally homicidal in this state, and we put, since Aurora, we have put institutions, not just a human, but institutions in there. So really know your duty to warn and who you notify and how you go about that. Do I hear questions?
I was going to say, Roxanne, I think one of the things to be aware of too is, what's going on in our environment, our world. And like the thing that happened in the recent days about the militia was going to kidnap the governor of Michigan and Virginia and so on. I mean, we know that during COVID, the sale of guns has like tripled. Mm-hmm. The use of alcohol is way up there. And I just think we have to be aware of even asking some questions. Sometimes, even if we just have that little gut stomach thing that you get uneasy, and sometimes you have to ask questions that
Mm-hmm.
you don't want to.
Mm-hmm. Domestic violence and suicide is also drastically increased as well.
Yeah.
Oh wow. Intimate partner violence.
Right.
We had a case just the other day. It started, I think it was in April, where there was intimate partner violence, and the police took all their kids away. And what were they arguing about? The husband wanted to take the children outside of the house, and the mom wanted to keep the children in because of COVID. And they had a fight. And so it's like it's just nuts what's really happening. Age of consent in this state, my state, Colorado, it just went down to 12. So, so I'm assuming it's still 15 in Florida. What's the age of consent?
So it's worded a little bit differently in Florida. That a child age 13 or older can request and consent to emergency treatment.
Okay.
But 18 is still age of consent for regular therapy.
Okay, so yeah, that's very interesting, because different states, different laws and rules there. So you have a child who's 12 in my state, or a 13 in an emergency situation in Florida, and they sign the informed consent, and they are told of their confidentiality. You can't bill the parents and no more than twice. And okay, Irma, can you talk about that for a minute? Can you explain that a bit?
Yes, it's for children in crisis, so they would have to be in a crisis unit for treatment no more than 2 times, and that you cannot bill the parents or the legal guardian. And then another area that they have protection is in the area of substance abuse treatment without parental notification. So I used to teach ethics, so I always told my students, your private practice is not an emergency room or a substance detox center. Mm-hmm. And so therefore, you need to make a proper referral. And I had students that were even part of private substance abuse facilities. And they even shared in class that those facilities don't want to take the minors because who's going to pay for the bill? Mm-hmm. So, you know, I think that that's one way of just reminding folks your private practice is really not set up. And then I use the example, you know, you're at the doctor's office and you start to experience, I don't know, a medical emergency or chest pain. They're going to call 911 and take you to the nearest emergency room because not even the medical practice is going to take care of you. So I just wanted to share that.
It's a great analogy. Yep. And I think, you know, I think this really just drives home for me the idea that we have to know and document our laws and rules. You know, we have to be documenting what this is. And, you know, you're also talking, Irma, about, and it's on later on the PowerPoint slide, is scope of practice, right?
Absolutely. So, yes.
Yeah. So although we may be, you know, in our scope of practice, we may be able to treat minors and, you know, substance use, but maybe that's not real. We're not the best person to do that. So if we're seeing clients that really should be in a different setting or with a different practitioner, that could come back as an issue in our as a medical error. Yeah. You want to advance?
Agreed.
Yeah.
Come on, computer. There we go.
So most of us know our mandates, right? I mean, all of you have been practicing for a very long time. So I'm sure you know that child abuse and neglect, elder or those unable to protect themselves. I had a situation though that was really interesting. One of my clients at student counseling told me that he and his grandfather got into a fist fight, and his grandmother wheeled her chair over to try and break up this fight, and she was knocked out of her chair. When I heard that, I went to my supervisor, although I was licensed, which was Douglas Flemons, and I said, all right. And he said, oh yeah, no, we have to report this. It was clearly elder abuse neglect. We called up, you know, the 1-800 Florida Abuse and found that they didn't take the case because it was voluntary. The woman voluntarily got in the middle of it. So again, with the nice to know with mandated reporting is better to call up and ask, is this a report that you would take? And document that you called, who you spoke to, what they said, what time it was, you know, that's where we get into trouble if that's not documented. And as they say, and I think this could just be the subtitle for everything, is if it's not documented, it didn't happen.
Which is a thing that I always struggle with, Roxanne, is if a client discloses something that someone else might perceive as mandatory reporting and I didn't do it, I should probably document why I didn't.
Yes, and I hate to keep invoking Colorado here, but I am following closely a case that would happen in any state. A woman who was I believe an LPC, which is an LMHC in Florida, was working in one of our local high schools right here. And last year, a young woman came in, the students came in and told her that on a bus trip, the head, and this is, you can look at Google this, the head football player, the quarterback, got her in the bus and sexually molested her. And she said, please don't report this. And so the therapist did not report it. What happened later was the young woman disclosed it again to someone else and said she had told the therapist, the counselor, school counselor. And now that counselor is under, you know, she's had her license removed and is under all kinds of investigation. And Mental Health Partners, who was her employer, has, of course, completely distanced themselves from her. You know, and so now we're watching this very carefully because it comes out to, like, if you hear something directly or if you hear it by hearsay, what should you do?
And so so this is the quarterback was over the age of 18.
As far as I know, he was under the age of 18.
So this was child on child?
You know, I'm still waiting to read exactly what's going to come out of this, but I was feeling for this woman because if a young woman said to me, here's what happened, please don't say anything, where would we stand on that? And what would we document?
I guess we would document that, and and if it was child on child, that's not child abuse, elder abuse, self of harm to others. It doesn't meet any of the mandatory reporting criteria. I guess one could call anyway and be told we don't take it and document that. That's
exactly the point, is when you have any kind of doubt, you document that you called, just like we did with the woman in the wheelchair. Which, and I guess HIV AIDS, now that's something you guys, handle in another course too. You're going to do that next week? Or?
That's the one that they're required to do before they get licensed. So they're not going to get that. Yes. We have a question?
Yeah, Roxanne, this is Walter. One quick question, just clarification. I thought I heard that on child sexual abuse, that somebody said that that's not something that would generate a report?
That was me, yes. Because it's not child abuse, it's not child abuse, it's not elder abuse, it's not abuse to someone who can't protect themselves, and it's not harm to self or others in the way that we think of harm typically. So so child on child is now a crime.
Okay.
Just it's a crime, but we don't report crimes.
Right.
That's outside of our jurisdiction. Now, this is what typically people do is they call the abuse registry. The abuse registry says, no, that should be called to police, but we don't call police. We don't do that because that's breaking confidentiality. If the minor wished to call police, we could certainly support that. But if she did not want to tell her parents and held us to confidentiality, we could not tell her parents. But we could document our attempts to support her to do that.
Yeah, I hear what you say, but I can't imagine. I hear what you in terms of criterions, and I just can't imagine.
So what would you do, Walter?
I would call immediately, and I'd call law enforcement, but I'd also call child abuse immediately. I'm just thinking, and only in terms of the cognitive ability to consent. I can't imagine that would not be a criteria that would initiate some kind of a call to authorities. So I could never document but not call somebody.
Larry, so calling child abuse. So Walter, you called the abuse line. They tell you.
I'd call, yeah.
Larry, would you please ring in on calling the authorities?
Yeah, Chapter 39 is the chapter in Florida that deals with child abuse. It's very complicated. It has so many little intricate details. I'm going
to interrupt you, Larry. Just take the opposite perspective. And what are the consequences for doing nothing other than documenting?
Well, I used to go to all the 491 board meetings. I haven't done that the past 2 years, but I used to attend all of them and sit. And I saw a really nice gentleman. I think everybody on the board thought this is a good guy, an experienced mental health counselor, and he got in trouble for not reporting child abuse when the family was a migratory family that reported something that happened in Mexico.
Right. I think
was in Mexico.
Wow.
So I think that because of the details, what I understand, Evelyn, it's not necessarily child on child, that simple, because it depends on if the child is a little older, a little younger, different factors like that. It also is like you may have a 17-year-old and a 16-year-old, and they may not take that saying, well, did they both consent? And so, you know, so that's what I mean. There's just a lot of details. I think also it depends on your county, because different counties in Florida have different agencies that have to be reported to. And so in some counties, I believe you have to report to the sheriff's department because they're the ones who are charged with any sort of child sex abuse. And so that's why I say, I think it's very detailed.
So would you agree though, to err on the side of caution, you would make a call? I'm only thinking in terms of children who are intellectually challenged.
Right.
Well, those are unable to protect self.
Right,
yeah.
right. Well,
yeah.
Okay, independent.
But Roxanne, in your scenario, was this a disabled child?
No.
And in this case, it was basically a rape.
No, it was sexual molestation. I'm not sure it was rape.
But it was sexual. It was sexual assault, so to speak.
Yeah, sexual assault, and yeah, it was surprising to me. This is why I think I'm driving this point home of really kind of, you know, maybe what you're saying, Walt, is like at least calling and saying, is this something you would take as an abuse call?
I would just hate to, could imagine being in court and trying to defend a lack of liability if you hadn't made some kind of a call or defend my liability.
Looks like Stacey has something to add.
Yeah.
I'm just wondering, you said that, this was not in private practice. This was to the school counselor, right?
Yeah, she was a practitioner that was assigned to the school. She was not a school counselor. She was an LPC, which is an L.
So she worked for an agency and was placed in a school.
Yes, yes.
Okay, okay. Because I'm wondering, like, if it was the school counselor, if they were hired by the school, I would think it would be a different story and
different chain of command.
Yeah,
exactly. And they also, school counselors, I think there's automatic, like they have releases to talk to everybody.
Right.
You know,
right.
And
so in that scenario, the school-based therapist probably should have gone to her supervisor and her supervisor's supervisor, and the agency attorneys should probably have been engaged, and then so that a lot of people were a part of the decision-making process.
Agreed. But think in your practices. I had a situation at student counseling where somebody, and of course it was over the age of consent and all that, but still a young client comes to you and tells you something like this happened, don't tell anybody. Our sort of adherence to our confidentiality is so great. Our standard 2 and our AAMFT ethics is like drilled into us that it's kind of almost you don't even think about it. You just, yeah, of course you have confidentiality. And in this state, she was over the age of consent.
Right. So if she's, so over the age of consent. Yeah. Okay.
Yeah.
But not an adult.
No.
Yeah.
No.
So if that same situation happens here in Florida.
Right. I'd say the process is the same. The content may be different, right? For me, now again, this is a conversation we all have. You got, Stacey, you're as experienced or more than I am. But I would think, does it make sense in terms of documentation, like Annalyn was saying, do you make the call or do you invoke other people? Do you at least call other clinical approved supervisors and say, what should I do? Document, so that at least you can prove due diligence. You know, you went through the chain of command. I mean, that's, I think we're really talking about how to when I first did this thing years ago, I called it a CYA, cover your ass. This is just a cover your ass, so that we can rebrand this to not medical errors, but CYA. And I think that's really what we're talking about is like, what do we do to protect ourselves? Not only because if we're protecting our clients, we are generally protecting ourselves too.
Well, remember with your association membership, we all have perks of free legal consults.
Right.
And even though they're not in your state, they will research and give you guidance. Again, you document, I made this call, that all that stuff. But that's a real good resource there. You know, we're not attorneys. Don't take it on ourselves as if we know everything. Like you say, reach out, get help.
Exactly. That's on my number one, I think, on my therapist safety plan.
Right.
Okay. You want to advance?
Did you want to talk about HIV/AIDS?
You know, I'm going to leave that to you since you're the expert on this.
So I'll do the quick in Florida. I don't know what it is in Colorado.
It's not. There's nothing to do with it. Yeah.
Florida has a option to report, but not a duty to report. And that option requires about 8 steps of that the client has to state that someone specific that they plan to have sex with unprotected. You have to document your attempts to teach them about infection and to give them resources, other ways that they could report the contact. And as I say this, I'm thinking COVID in my head, right? When is that going to start popping up, right? That we find out, yes, I plan to cough on my ex and make them have COVID, right? So that we have to talk about how else they could inform them. We have to disclose to them that we're going to tell the other person, at which point we're likely to lose the client, as you might imagine. We then have to contact the intended, victim,
Mm-hmm.
But you cannot tell party B who party A is. You can only tell them that they are at risk. You have to document it in separate charts. And I believe the law says that you have to have party B come in face to face to do this, for which you can get no money. You have to have a separate chart and keep all the information separate, right? That's why most places say, I'm going to exercise my right to not report, to not tell the other person.
And I don't know for the rest of you, but for me, what it would come back with HIV, is it an intent to kill, right? Is a person saying, I am going to use my disease to kill another person? Even though now with HIV, that is not a death sentence, necessarily at all. But I think it comes back down, for me, I look at it like duty to warn. Although as you're talking, Annalyn, it's got that super confidentiality component.
Aspect to it in the documentation, right?
Mm-hmm.
Specifically in the documentation. Yeah.
Right.
So really the HIV/AIDS piece is all about documentation, documenting that you went through all these steps.
Mm-hmm.
Yeah. Thanks.
Okay. Yeah. Let's, I guess, kind of go.
Yeah.
forward.
Let's mush on. We've got not very much time and a lot of
know.
slides.
And so child abuse neglect reporting, I think we just talked a little bit about that. But again, what I like to really remind ourselves is we are not the investigator. We only have to have suspicion of abuse or neglect. When it says assessment here, Larry, and this was from your slide, so I was going to ask you, do you or anybody think we have to do a child abuse assessment? Because I was not, it was just a suspicion.
No, in fact, depending on the age of the child, I think there is statute that says that they can only be interviewed a certain number of times.
Yeah,
and we don't want to burn through one of those times by making that too intensive.
Mm-hmm.
Larry, were you going to say something?
No, I agree.
Yeah. And I think, again, documenting when I see documentation, and I've helped some of my interns make these calls too, and probably some of you have too, is being on the line and giving as much information as you have central to the potential child abuse or neglect charge. So not, I've had investigators call me back and say, oh, so what were the parents in for? What were, they wanted to know more information that didn't really have to do with
then comes confidentiality. And so from a documentation point of view, if you Google Florida child abuse hotline or reporting or whatever, you can actually get a fax page a blank fax page that you can print off and use that to determine all the information that you need to gather in order to send it to the state, or even if you just call. And then that can be your documentation in your chart, is that you got all the information, the name of the alleged perpetrator, information, contact information, address, phone, guardian information, all of that kind of good stuff. So that's it gives you what you need to give, and what the therapy was in, what the clients were in therapy for is not one of those items.
But I mean, it can sometimes be slippery again, because an investigator can call you back to get, to verify the information, and all of a sudden you're in a chat, you're like, oh, and so you have to very much be very careful. And then of course, absolutely, when we talk about documentation, you document the person's badge number and what time you called and what everything that that you did, so that you hand off, what I call is handing off the hot potato.
Right, because I believe that's all on a recorded line. So if you document date and time, that's another way to document that you made the call.
Right, and I think I'm sorry, go on.
I see a lot, because I see the petitions all the time in my work, that therapists are getting led into these conversations where they are I see them day after day, and it's really infringing on confidentiality. It's scary.
Oh, thank you, Heather. I'm so glad you're here tonight.
I remember back when I was an intern at it was called Family Therapy Associates back then. And I was on the phone with an investigator who called after, and I, as an intern, was like, well, am I supposed to say this? Am I supposed to? And it was very slippery. It was very like, well, kind of chatty, and, and so being really clear about, like, I love this, Annalyn, is here's the template, here's what I can say, and here's what I can't say. So having that clear.
Yeah, if they call you, get your form back out.
Yeah.
Right.
Yeah. Well, I mean, now and probably everybody here, but so you went over this stuff. Did you want to do anything any more about this?
I don't think so. It's about, this is the super confidentiality nature of this. This is not so much about us, because we're not going to, we're not the phlebotomist, but this covers all of them as well, phlebotomists, and the need to not document this. If a client tells you they're HIV, you can put that in your chart. You can actually write that. You don't have to write the life-threatening blood disorder, because everybody knows what that's code for. So that's kind of silly. But so there's that stuff, and there's but again, let me go back. If you want to grab that that statute 456.061 and look that up for yourself, that is that's a place where you can find that information. Oftentimes people will contact me, I know this is in the law, but where is it? Right. Yeah. So it's good to have these. But if we're in good faith advising the sexual partner, we probably will not lose in a suit against us for breaking confidentiality, but that doesn't mean we avoid the suit altogether if someone wants to sue us. And that's the problem with that.
When we were in student counseling, our sort of litmus test was always, if we're going to be sued on the stand, do we want to be sued for breaking confidentiality, or do we want to be sued for something else? So you have to sometimes weigh those. So scope of practice errors. So as a licensed marriage and family therapist, our scope of practice is pretty big, defined by the state. But that doesn't always mean that we have competency and training in stuff. We might have to show, say, if we're working with someone with trauma, or we're working with somebody suicide, or we're working with someone that has autism or anything like that, what training do we document? What training and competency do we document?
Or in a particular technique, if we we want to use EMDR or something like that, we have to show competency in that before we can do it.
Exactly. I just lost my train of thought. With diagnosis too is oftentimes, and I saw this meme on Facebook, which it's like this guy rolling his eyes. I think it's what's Robert Downey Jr. rolling his eyes, you know, if you've seen that meme. And it says, I'm supposed to assess my clients a certain amount of times before I can diagnose them, because many agencies want that diagnosis right up front, or even before you've even assessed them. They, you know, there's that diagnosis
in that first hour. Yeah, they want it in the first hour. Mm-hmm.
And when you tell, you know, an agency, or you tell even an insurance company, well, I don't have a diagnosis yet, you might not get, you know, paid. So, but again, our scope of practice errors is say when we either diagnose someone incorrectly, or we don't update the diagnosis. Say years ago they came in with an anxiety diagnosis, or you know, have you reassessed them and re-diagnose them, or drop the diagnosis? So I think it's very important. Now, one of the things I say in my ethics class, and most of you are couples therapists, so this is one of my really big beefs around scope of practice errors, is when a couple comes in wanting marital treatment or couples treatment. And of course, that might not be covered under their insurance policy. But you say, well, wait a minute, Mrs. Jones, I'll take your insurance card first. And, you know, how about a generalized anxiety disorder? Does that sound okay? And then you treat the couple. So that, again, is a medical error, you know, because you are what's the word? You're incorrectly diagnosing them.
You're doing fraud?
Yeah, fraud. Yeah, fraud. What's that word again?
I don't necessarily agree with that totally.
Okay.
For this reason. Blue Cross Blue Shield, I'm a preferred provider, although I'm probably going to quit pretty soon with that. They call me and they'll say, we know you do couples counseling, we know you do family, we've got these people that have reached out, we want you to see them. And they know that they want to use their insurance. And so what I say to people, Roxanne, and I may not be right, is they don't care how many people are in the room, you know. They don't really care about modality. So if you've got a legitimate thing, such as, you know, an adjustment disorder because of the stress of the conflict or whatever, I don't think that's a practice error necessarily.
No, I don't think
if it's legitimate.
Right.
Yeah.
And I would also think, I think where we get into the salient point is when we diagnose somebody with one thing, but we treat them with another. Yeah. And I think that is a medical error there.
Well, in DSM-5, whatever you're treating them for is supposed to be the first thing that's listed. And if they're really there for couples conflicts, then that's the first thing that should be listed. So it's not, we think systemically. So certainly if they're coming because they're having arguments over whether to go out because of COVID, and there's a lot of this adjustment, you know, around that, certainly that's a relational issue, right? But yeah, it's which comes first. And so we really have to be honest and transparent about what we're treating them for. Eventually we can make it all link up. I mean, we can link up almost anything, but we have to really understand what, you know, also anytime there's a record of that kind of thing, that's a permanent record. I mean, well, it's at least a 7-year record. If it's the insurance company, it probably is lifetime. So you got to be careful what you do if it's not real.
And for me, the transparency of letting people know their diagnosis. Oftentimes, clients will say, well, I used my insurance card when we went to couples therapy with our last therapist. And I said, oh, okay, well, what was the diagnosis? And they said, oh, we didn't get a diagnosis. And so therapists don't have to disclose the diagnosis. And that to me, I mean, that is an issue. So I think really being transparent around, you know, what we're diagnosing, how we're diagnosing it, how we're assessing for that diagnosis, and then are we treating for it? Is our treatment plan aligned with the diagnosis and assessment?
Well, what you're saying there is that we need to document the entire golden thread. What did they say they came in for? What did we actually assess? And based on what we assessed, does that connect to the particular diagnosis that we then ended up with? Can we see the line that goes between them? And then also into our progress notes, right? Mm-hmm. Do our progress notes then follow from everything else that's come before?
And that's really good point too, is the progress notes being aligned. And like I like this, the golden thread that goes through it. Okay. Questions about that? Because I saw, okay, go ahead.
Frequently, I will use a relationship code when I diagnose, but frequently I'll use more than one code. Right. So I put it on there. My insurance company submits. It's got it on there. I'm not trying to, throw off Blue Cross Blue Shield. And if
Larry, let me ask, if you put generalized anxiety or adjustment disorder and, spousal conflict or whatever, right. Does it matter which order it's in for the insurance company, or do they just kind of see it all collectively?
I don't know I'm not sure I can answer that.
Okay.
Yeah, I don't know for insurance.
Okay. Last quarter in my ethics class at Capella, I go over this in one of the units, and I had a learner who is a person who does investigation for this at for an insurance company. Ah. And so when we brought this up, she really led the discussion a lot and said, you would not believe how many people that they investigate, and that do just that they take the card, they put whatever that can get down, they change when they've done that treatment plan enough, they use another code, another diagnosis, and they keep going and going and going.
Just a series of changing diagnoses.
And they could be seeing clients for a long time. And so I think that, and she said that happens a lot of the times, and insurance companies, I like for you, Larry, they're calling you up and saying, please see these people, right. That's great. But sometimes, I don't know. Anyway, that is a scope of practice error too,
Okay.
Okay, next, yeah.
So we've got a little bit of law there to look at, 64B421.
Mm-hmm.
So it gives you what the Florida licensure says you can do. But as you were saying, Roxanne, just because it says you can do it doesn't mean you should do it if you don't have training. So for instance, exactly. Sexual dysfunction. None of us got enough training in our master's program to really treat sexual dysfunction. So if we're going to do that, we probably need to either get additional training, additional mm-hmm. supervision, whatever, in order to do that.
Exactly. Good point. That's okay. Again, this is more support your diagnosis in your notes and documentation, regular reviews with appropriate changes, right? So reassessment. And I like this question, and this is Larry's question. If an expert reviewed your diagnosis, would it fare well? Right. So really looking at your case documentation from the eyes of my student last term, if they were investigating, would, are your case notes timely? Are your diagnoses current? Are you, is the golden thread through that? So
yeah, could someone look at your biopsychosocial or whatever assessment you do and highlight to see, okay, the client said these things and that leads to this diagnosis. Can you make all those connections?
Mm-hmm. Well, till very recently, Sandy, my wife, was on the probable cause panel in Florida for 491 as a former board member. And the process is a complaint comes in, the attorney looks at it on the board and says, well, it does pertain to the law, And then they'll send it to the board, and the board will look at it. But what they always do is, if they move forward, they'll send it to a probable cause panel. And the panel is made up, it's supposed to be made up of 2 former board members and the attorney and the executive director of the board. So that they're the experts. They're going to be reviewing. And many times Sandy, I don't know specifics case, but I know she will say, yeah, we had a case, and she'll say, we reviewed it and we said nothing out of the ordinary was done there. You know, that this person followed protocol. The staff at the Department of Health don't know that. They're not experts, you know, on it. So, and sometimes, you know, Sandy would say, yes, there was an error, and we kind of suggested to the board, you know, this was not protocol. This person did blah, 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 you know, just like Annalyn said. They were trying to, well, one of the common things I think is clients will ask us about medication. You know,
oh, right.
You know,
that's not even on that list.
No, not at all.
Yeah.
And yet, and I know therapists who call doctors and say, you shouldn't be giving them this drug, you should give them that drug. You know, so.
It's a bit of hubris there.
Yes, yes.
Right. Wow. Well, I think what you're really saying, Larry, what I go back to all the time when I'm like, if an expert reviewed my stuff, is what's best practice? What would therapists that with similar training do? And that's where really consultation comes in, with other therapists, with clinical supervisors, with your state attorney, your attorney on your CPA or your malpractice insurance, you know, is you know, really consulting with those things. Yeah, I can't imagine telling a client what or even, you know, I had someone in Broward too who's actually an attorney, and she was becoming a marriage and family therapist, and I was the supervisor behind the mirror, and she kept trying to, and she was a good attorney, and she kept giving attorney advice, and I kept beep, 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 you know, because we have to know our scope of practice when we're in that chair. Even if we have expertise in another realm, we have to, when we're in that chair, we're a marriage and family therapist, we're not an attorney, we're not a PA, we're not, you know, a medical person at all. So, yeah. And then, yeah, I think we were just talking about this. We can.
Okay. Just the only thing we really didn't mention specifically was treatment plans. And so even though, I mean, I don't know what people do in private practice. I don't know what their documentation looks like. So those of you who are in private practice, I'm curious to know, what do your formal, if you have formal treatment plans, look like? I know what Medicare nonprofits use, and they're very extensive and sometimes multiple pages with a problem statement and objectives and you know, timelines and measurable goals and all of that kind of good stuff. I'm pretty sure that most private practitioners do not go through all of that, but maybe they do. Stacy, what do you require at your shop?
We have a EHR, and in our electronic health records, there is a treatment plan, and yeah, they are required to fill them out.
So you kind of let the electronic record format kind of dictate that. Okay.
Yep. Yeah.
Okay. There you go. There you go. All right.
And I think now with like I'm just blanking on the electronic records that we're getting a lot. The oh my gosh, it's like a Google thing, or Gmail. Anyway, it's just all the forms are already there. So my interns often say, here's all the forms, and they're all the same forms. They're from I forget what.
Like TheraView or some of those
TheraView, like TheraView.
Okay.
There's another one too. So it's sort of like, you know, these are the accepted, expected treatment plans and, you know, documentation, which I think is really good, especially for new practitioners, because, you know, it's already there. It's already been developed. It's already been looked at by attorneys. So, right. So here are some of the things that you were just saying, Annalyn, some of the things that may go into a treatment plan, you know?
Yeah.
Yeah. Okay. Wanna.
Oh, records. Okay. What are records?
Right. Records. Here we go. I love this is from Larry, you know, of course, but I love the little picture of the guy with the the file cabinet, because I still keep paper records. But again, I have between 5 and 8 clients a week. So I still do the file cabinet under 2 locks and the whole deal, you know. But I'm a dinosaur in this field right now. So I'm wondering, you know, this is an old thing. So does anybody still do paper records? You do, Annalyn?
I do.
You do? Everybody else is doing electronic. Yeah. Okay. So again, the upside of electronic records is you really have those templates to follow, and they're standardized and they're, you know, accepted. But so let me ask a stupid question. How do you make sure? The old way is, you know, behind 2 locks, but what are the acceptable ways for electronic health records?
Stacy, what's required to get into an electronic record at your shop?
There is a password that each therapist has, and then that I don't have, and there's a secondary password that is required, and then I require everyone to have a password on their own computers. So there's
there's a password to get into the computer, password to get into the system, and then there's a password to get into the record that each individual therapist has. So it's like 3 locks.
Yep.
Okay. So here's a nice list of the records that need to be in the file. It doesn't say what it's supposed to look like. It just says these are the things that need to be in it. And I believe this is from the Florida Administrative Code.
This is the rules, yeah.
Yeah, this is from the code. So 64B4 is where you would find this. So it has all these different things that need to be there. If you go into 64B4, you can get a copy of this for yourself. And I think, Larry, didn't we do research once that one of the pieces of documentation that get people tripped up is lists of payments, record of payments that have to be in the record. In some kind of way. So yeah.
So that I'm gonna you know ask about Florida. So in Florida, in the documentation in Florida, you have to have within the file or the electronic health records a list of payments that because I don't have that in mine in Colorado. We don't. I am not aware of that if it is. So, I mean,
so financial transactions, there it is right there. So diagnosis, financial transactions, fees assessed and collected.
Right, okay.
Yep. That's a requirement that it be in the file. Yep.
So if you're doing gratis work, you just put, you know,
pro bono.
Pro bono,
okay,
right. So you would, but again, you have to document, right, Stace?
Yep.
Yeah. Okay.
And my electronic health record goes as far as whether it was a cash payment, a credit card, a check, what the check number was, all of that.
Yeah.
So this is interesting too. Who pays for the services does not have a right to the confidentiality if someone else is going. So mom and dad are paying for the therapy, but teenager is attending. Teenager still gets the confidentiality. The fact that the parent is paying for it does not give them the right to break confidentiality. That's not among the 4 things in confidentiality.
What about age of consent though? So parents,
if they've written consent, if they've consented for their child to be seen and then says, please see Johnny by himself, Johnny gets confidentiality. Which is why, as all people who have supervised under me know, I will beat you until you remember to always have a guardian in the room with a child. Always.
When Stacy may do some of this at your agency, was with EAPs. And when I contracted years ago with EAPs, they're paying for 4 sessions or whatever. And I said, only thing I'm going to let you know is they came, how many times they came.
Right.
That's it. Nothing else.
Exactly.
Larry, did you put that in your informed consent as well, that you were going to tell the employer that?
Yes, for the EAP, I added that to the informed consent.
Right. So they were essentially consenting to you providing the employer that information, or the EAP entity, the information.
Right.
Okay. Okay.
We've
Cool.
got about 10 minutes left. Let's do this. I think we've already talked about, right?
We did. Yeah.
Okay.
Yep.
And many people I know, well, making sure you document fresh, not like a week later. Yeah. Do you guys want to go over this?
Well, you can look it up for yourselves, and
Yeah.
we will. And for those of you who take the Laws and Rules refresher in the new year, we will go over a number of these things. But these are penalties around documentation, about fraudulent documentation or the failure to document. Those are all in there. Also, it's also against the law to compel someone else to fraudulently document. So like the student who came to me and said, I've started my job in September and they're wanting me to write treatment plans dated back to July. That kind of stuff, that's against the law because that's a documenting error in the law. So let's see, failing to provide written notice of the type of license, right? So that's, displaying your license, otherwise being truthful about what your license, your credential is. A day probably doesn't go by that I don't have someone, a registered intern, email me and they've put it initialized in their signature, and I write back answering their question, and I'll say, and you need to change this in your signature because that's not allowed. I don't know why people don't know this, but yeah, it's one of those things that has to be there. All right. Go ahead.
I'm blanking right here. Reducing errors in okay, this is more about diagnosis. So let's just go. I want to, because we've only got a few minutes left. I kind of want to go to writing the therapist safety plan.
There we go.
Yeah. This. So I always say, we write safety plans with our clients in mind, but we have to really think about our own safety, and keeping our license is like the #1 safety thing. So I think I said this in the very beginning. I think I might have said all of this is avoid isolation from other professionals. What I really recommend is coming up with a therapeutic supervision group, even if you're long licensed. Having that meet regularly. Also, what I've done on the Colorado Board for Marriage and Family Therapy is I've had our state attorney, who's Dennis Lane, and Jeremy Shufflebarger, who if you call CPH, they'll refer you to these folks in Colorado. I have them come in every year and update us on the new laws and rules, and so that we know them, so that we can document. And I know you guys are getting those CEU courses in laws and ethics. And going back to best practice, that's where the consultations come. What would another therapist in your same situation be doing? Maybe calling 2 or 3 people. I think every time, and many of our journal articles show this when we're in ethics, is therapists knew something was wrong. Almost always when they lost their life or something happened, they knew something was wrong. They just didn't know how to address it. So I always say to my interns, and you probably do this with your interns too, is what's your gut saying, and then listen to your gut. Like where was this off? And then finally, like the last one is cover your ass. And that means, again, document everything. And doing this all the time throughout. I mean, it almost is second nature. I bet you everybody here does this. You have a weird case, you have a hard case, you think there's something wrong. You call your buddy, you went to maybe call Anna Lynn, I might call Paul Maoni, I might call, Douglas Flemons.
We call each other.
Yeah, and say, I got this weird case. And now here in Colorado, I have a good friend, and you know her, she was the president of presidents, Jen Matheson. She works like next door to me when we had an office. And I say, hey, what would you do here? And she would do the same. So it's always that. And then I spoke with Jen Matheson, spoke with Jeremy Shufflebarger, and that's my therapist safety plan. Do other people have other safety plans that they do? What else? Heather, you're shaking your head yes.
I have 2 therapists in particular, and someone who's like over our program as well, that when I get something weird, I always call them. and then kind of compare their answers and then follow up with them again too. Because I'm a little isolated as well, since I'm surrounded with social workers and I'm really doing advocacy work, but clinical stuff is always coming up. I have something tonight I have to call about staff after this. So, and that's one thing I say to my staff too, don't do something in a vacuum. If it's weird and you feel like you can't go it alone, don't come grab me, come grab someone else.
Right. Heather, let me ask you, when you make those calls, do you then document by name, called supervisor, called this, and this is what they advised me? Do you put it in your record? I got people nodding their head. But you're kind of holding still there, Heather.
Yeah, I haven't, and I might need to. My documentation is a little bit different because it's documented in the public defender documentation system.
Okay, but as a clinician,
on the side I do. On the side I do, yes, but I didn't put it in my actual documentation at work, but I'll write it up.
Okay, so you'll have it documented somewhere that you made those calls.
Yeah, I always say when people call me, because they know I teach law and ethics, they'll call me and I'll say, document that you spoke to me, you know. And so, you know, we're doing best practice. And also, if I don't know it, I say call CPH and get it. I've had so many of my interns go, I didn't know I could just call and get a free consult. I was like, you're paying for it. It's not free, you know. So I think it's important to document that. So we've only got a couple minutes left, but I wanted to get
a question about.
Yes.
So that made me think about, in the consent form, there should be something said that you might consult with others without their name, I guess, right? But details are going to be more than just, you know, basic when you are consulting with somebody.
It's a good point. Well, all, you know, interns have to have that in their paperwork that they are, but that's a good point, you know, that do clients have to consent for us to consult? In our ethical codes, there is there's a piece in our confidentiality, I'm trying to remember which standard it is, around confidentiality in consultations. So we generally have to do what I think you're alluding to, Sophia, is not identify the client by name or by identifying information, especially I guess if you work in a small town, or like it's student counseling or something, or that's like a small town, you have to be careful about not, you know, breaching confidentiality, but also doing a consult.
Listen, just because of you reminded us in your objectives, Roxanne, that one of the things we have to mention to be within code here is root cause analysis.
Okay, do that for me.
Right. Root cause analysis is basically tracking how did this go wrong? Where did it go wrong? Right. And Larry likes to always present the 5 whys. So you know, what happened and why did that happen? And why did that happen? And why did that happen? And you go back 5 whys, right? As so the one that I think, Larry, the one you like to give is that something went wrong, you know, somebody didn't do something correctly. And so why is that? Well, because I didn't get training. Well, why didn't you? Well, because the supervisor didn't believe in it. Well, why didn't the supervisor believe in it? Well, because he wasn't being properly supervised, right? So you trace it back five times, 5 whys, as a way to get back to where you need to start working on it. Guys, we do this all the time as clinicians, right? Johnny's not passing math. Why? Well, because he's not going to class. Why? Right? So you just back it up. So it's the same kind of thing in terms of our own decision making, right? To back that up, to look at the root cause of that. And it sounds a fancy, root cause analysis, and there's probably all kinds of theories and stuff like that about it.
And in medical editors, medical.
Yes, absolutely. This is, particularly when the wrong leg was cut off, kind of thing.
Right.
My partner just had hip surgery, and she laughed about that the orthoped came in and signed his name on the correct leg, right? And in fact, I've watched where they've handed the pen to the patient and they put an X on the correct limb, right? So I'm sure, I would hope they document all of that. I'm sure they do, but it's these kinds of things that is the root cause analysis of whenever something goes wrong. If you've made an error in your documentation or an error of any of the things we talked today, is to walk yourself back or to walk that person back 5 steps to figure out.
And one way that you can do that more easily, I think, is following the decision-making model.
Right.
And so you can, I mean, if you don't remember Kitchener's model or Kucher-Keith-Spiegel or any of the
these are the ethical decision-making models.
Right. But it also talks about documentation. So I think it's not maybe root cause analysis, but I think it may be more of an equal thing in our realm as opposed to a root cause analysis in a hospital setting.
Yeah.
Sounds like almost like a postmortem, the root cause.
Absolutely.
Right, it is.
It is exactly what that is. Yeah. Yeah, the idea of it's not enough to say something went wrong. It's what are you going to do about it? And of course, documenting that. And any of you who have practices where people work for you, I'm sure that that's something you go through sort of spontaneously to figure out how could we have made this better and learn from that. Quality improvement, all of those kind of ideas. Yeah.
Right.
Well, any last thoughts? Anything that you guys wanted to be sure we talked about that we did not get to? Did we get to it? There may be some telemental health things that we will talk about. Thank you, Larry, for that nice thumbs up. We will be talking about that, I'm sure, in our telemental health workshop, which I believe we're doing in January, Larry. I think that's when we're planning that. One of these coming up months, January, February, March, somewhere in the, so check the Thin Facebook and our website. It's Florida Interest Network -AAMFT. And all you got to do is answer 4 little questions about how it is you're an MFT. I want to make sure people don't subscribe to it who are trying to sell us stuff and are not MFTs. So I will quickly approve you because I know all of you. And that is where I do post the links and all of this kind of information. If you haven't already, if you need CEUs and you did not purchase it through the Florida Therapy Alliance website, then be sure to put your information, your name and your information in your email, and Larry will help you pay for it, and we'll get you those CEUs in CE Broker. For those of you who are listening to this not live, we'll be providing that information below in YouTube. Edie.
HIPAA. We didn't cover anything on HIPAA, which someone mentioned. And then the second question I have is, if we belong to AAMFT, do we also need to go in and belong to FIN and the family? I'll forget what they're called.
So family team is free for anybody.
Okay.
FIN is a whopping $25 a year to belong. And yes, you have to be an AMFT member first because we are affiliated, as opposed to FFTA, which is not affiliated. Right? So that's a separate entity. And HIPAA, of course, is federal. And I was, as someone was mentioning it earlier, I just Googled HIPAA training online for free. And the HHS.org, in fact, if you look in the chat now, way back at the beginning, I provided a link. At least I'm pretty sure I did. I provided a link where you can get free training on HIPAA. There it is, the hhs.gov for professionals. And so there are opportunities for you to do that. I don't know if you'd get CEUs for it, but of course it's the Health Information Portability and Accountability Act. So it's about anytime you're going to transport, move documentation, and of course that's going to be all of your electronic records. So all of the rules about that, and some of them are kind of obscure. So rather than depending on us to talk about that, I would recommend to everyone get specific HIPAA training through these free sources. Thank you, Edie, for reminding me of that. All right. Well, if that's all, I'm going to go ahead and end this recording, but we can stay and chat if you like.
Great.